Hi everyone, thank you for the invitation and the introduction. It's a two-person presentation just to also keep you awake after lunch. So we're going to talk about a systematic review. We're a research team based mainly at UCL and King's that conducts, generally we try to make it fairly rapid research in response to policy needs from the Department of Health and Social Care and others. And we were asked to conduct a review on mental health needs in response in following COVID, particularly for Department of Health and Social Care analysts to inform their forecasting. And I'm going to introduce and comment on a review that Nafiso led with a huge group of researchers, lived experience researchers, some epidemiological experts, including Rob Stewart, who's here. A large team got together to conduct this review fairly quickly, and hopefully if we ever manage to get through all the corrections, it will shortly be out in Lancet Psychiatry, but it is a bit of a battle. And we focused, in order to try and reduce the sort of variation in waves and government responses and stuff a bit, and also to make it more manageable, we focused on Europe only, and on higher income countries in Europe. And our research questions were, both before versus after and during the pandemic, how did incidence or prevalence of mental health conditions change? How did outcomes for people who were already living with mental health conditions change? And that's a particularly novel question in terms of what's been looked at in reviews. And then what changes have there been to mental health service use? Thank you.
Hello everyone, I'm Nafiso. So I'm going to quickly go through the methods section and the results for each of the questions. It's quite a lot of data, so it might be a little bit rushed, but we searched 4 electronic databases and 4 preprint servers in February 2022, and we were looking for primary research relating to mental health and COVID-19. We had a very extensive search, but these are some of the terms that we used. So here's our eligibility criteria. We included studies depending on the research question, general population. So that was for research question 1, so the incidence and prevalence. And for research question 2, for the outcomes there, we looked for people with pre-existing mental health conditions, and changes in surface use was both, a combination of both. We included studies that had both the before and after comparator, as well as between different points of the pandemic, so over the course of the pandemic, and we included longitudinal and longitudinal cohorts of studies, as well as a repeated cross-sectional design. So I'm not going to be able to talk too much about this, but we assessed the certainty of evidence, so the strength of evidence for each of the outcomes, and we did this independently by 2 researchers, and we, as well as the study quality that we assessed using the Newcastle-Ottawa scale, we considered these 5 domains for the strength of evidence for each outcome. So here just shows you the process of how we reached 177 studies included in our review. And this is a really detailed slide of our study characteristics. So I'll leave it up here for you just to kind of see the different types of studies that were included. So the majority of our studies came from the UK, and the majority of the studies rated as high quality.
Okay, so for the first research question, which was looking at what changes there have been to prevalence and incidence of mental health conditions, we found high to moderate certainty of evidence that the prevalence of depression and anxiety was higher at the onset of the pandemic. And then there was very low certainty of evidence that eating disorder may have also increased, but there was limited evidence from other major conditions, including psychosis, bipolar disorder, and personality disorder.
the patterns of change for the studies that looked at over the course of the pandemic was less clear. So it was very mixed evidence. So you could see that there was some no changes in depression, some reductions in PTSD, moderate to low certainty of evidence, anxiety. So it was just very mixed, so no really clear patterns of change for the studies that looked at over the course of the pandemic. So the few studies that looked at incidence of mental health problems, there's only a handful, I think it's about 3, and they were based on service contacts, so health service records. They showed a reduction at the onset of the pandemic, which is something that we expected, and you'll see from when I present service use data that there was reductions at the onset of the pandemic in service use. So for the changes that there have been to people living with mental health conditions, there were several outcomes for this, but in terms of adult clinical populations and changes in symptom severity, overall for this question, the evidence was very low to low certainty. We had the most outcomes for this question and only a few contributing studies for all the outcomes. So I've tried to pull out this for the adult symptom severity, the moderate to high certainty findings. And as you can see across, there was no change. So there wasn't really clear patterns of changes here. But for children and young people, so we did analyze these studies separately again, only a few contributing studies, so it wasn't high certainty evidence, but there was some indication of very low certainty that there was worsening of some conditions in children with pre-existing conditions. So across those, so OCD, general psychopathology, depression and anxiety. Again, for all the social outcomes that we measured, it was different findings for different outcomes. So you can see some of the outcomes we found for social functioning, that there was worsening, some improvements in psychosocial outcomes, and then no significant change in quality of life. So it was just very mixed for this research question and not much. It had the least amount of contributing studies for research question 2. Yep. Suicidal behavior and self-harm, I think there's only about 3 contributing studies, and similar to before, where it was measured through clinical records, we found reductions, and the self-reported suicidal ideation and self-reported self-harm, it was different directions. So the findings for service use majority were high to moderate certainty for this question, and the patterns of change were a lot more clear. So we found that in the onset of the pandemic, service use decreased substantially across services, and this included acute mental health care, so inpatient emergency department and crisis care, as well as the community mental health services and the primary care mental health related contacts. The exception was the trauma and resuscitation units, which reported increased admissions based for people for suicidal attempts and traumatic injuries. And then as the pandemic progressed, there was decreases still in some services, but not all. Some services started increasing. But this is just for the before and after studies. So then changes during the pandemic, there was increases in most services after the initial drop. And then there were some services, particularly pediatric emergency services and community mental health services for adults of working age, that showed evidence of rise above the pre-pandemic levels. But most services were showing increases, but it wasn't to pre-pandemic levels. So that's all from me. I'll pass you back over to Sonia.
Okay, so what do we make of all this? Well, essentially, there are some signals, there are some areas of evidence of impact, probably a sort of little rise in depression and anxiety at the onset of the pandemic, and certainly evidence of unmet need at the onset of the pandemic, in that there's this mismatch between the fall in service use and the rise in mental health conditions. There's considerable weakness in the evidence Most of the evidence is on depression and anxiety. Most of it is on the earliest stages of the pandemic. And these tend to be studies with symptom measures for which a cutoff point has been designated rather than full diagnostic assessments. We don't really know anything about conditions like psychosis, bipolar, people with a personality disorder diagnosis. The children and young persons literature is quite limited despite the concerns. It's not the tsunami, is it? Or even a second pandemic. And it doesn't match the rhetoric about mental health conditions at the onset of the pandemic, which is surprising because people's predictions were very confident, weren't there, that there would be a big impact. So are we not seeing that? Well, there are quite a few qualitative studies now looking at people's reports about the mental health impact, for instance, for people who are already living with mental health conditions at the onset of the pandemic. And they suggest, as perhaps for the rest of us, that the impacts, the experiences of the pandemic were pretty mixed. That, you know, there were people for whom it was people who stayed at home and watched Netflix and reconnected with old friends, and others who had a disastrous time. And they are very different narratives that need unpicking. The resilience of people with long-term mental health conditions is another thing, that if people are already isolated, already living in considerable adversity, perhaps they were actually quite well equipped in some cases to cope with the onslaught and the challenges of the pandemic. We know, don't we, from various things, that the already marginalized groups, like some ethnic minority groups or people with severe mental illnesses like psychosis, were particularly vulnerable to the pandemic. And on the whole, we don't really see much of these groups in the studies that have been done. So it's a pity. There are loads and loads of studies focusing on measures of depression and anxiety, but on the whole, across the population, we don't get to find out, except in certain service use studies, what happened to people with psychosis and bipolar, what happened to people from ethnic minority backgrounds represented in big enough numbers. This absolutely shouldn't make anyone think that there is no mental health crisis, because the reality is that there already was one. So demand for services was already rising steadily over quite a lot of years, particularly for children and young people. And obviously what happened at the beginning of the pandemic was that service use dropped. The incidence of mental health conditions, if anything, rose. And that, of course, gives us a further mismatch between, that's exacerbated probably the gap between need and provision. So I'll just leave you with this. So one thing we do in our policy research unit is our lived experience researcher colleagues, for all the papers we publish, there's a separate commentary included, which we found journals have pretty much always been happy to publish, written by some of our lived experience researcher co-authors, giving their perspective on the piece of work. And this is the one that, as I say, if we ever get there with the corrections, will be published next week with this paper. And their view essentially was that they were fairly unimpressed by aspects of this review. One thing that was pointed out was that none of the many studies seem to have had lived experience researcher input into deciding what it was important to look at or into interpreting the findings. And again, they very much pointed out the missing perspectives, the groups whom we know to have been particularly vulnerable in COVID, who have not really been looked at. Okay, thank you very much.
So we've got We have a few minutes for questions. Thank you so much for a clear and really compelling talk. There aren't many issues that could be more important from this, and I think there have been pieces of information coming out. I remember the first was from Rob Stewart in the audience showing that there wasn't a massive wave of people admitted with severe mental disorders. There weren't increasing rates of people coming in and being given treatments for treatment resistance and other indicators that there might be some sort of tsunami. So I think it's fascinating. The findings are fascinating. I wonder what lessons there are for us here. I mean, there must be many lessons, but there was a kind of collective, perhaps, a collective talking up of the dangers to mental health. Do you think we could have, as a field, handled that better in hindsight?
Well, I mean, I suppose pointing out the dangers is never a terrible idea, really. And I think one thing that our lived experience researcher colleagues said was that they felt that the challenges that were already faced by the mentally ill were in danger of being forgotten, really, during the COVID pandemic. So to be honest, advocating for the needs of people with mental health problems is never a bad idea, even in an emergency of another kind. But I guess it kind of points again to the need to maybe to think in advance about emergencies and how we maybe might avoid the same study being repeatedly done when actually we need data on a range of aspects of what's going on that wasn't really obtained.
Thank you. Anne.
So absolutely I did a lot of work on suicide and suicide prevention, and we had exactly the same phenomena. The only thing I wonder, and this doesn't apply to suicide prevention, but potentially does apply to all the symptoms and mental health. So, there's this paper coming. There was the paper in the BMJ a couple of months ago showing similar findings. But do you think, so we focus very much on clinically relevant changes in the population, and it's me. So what I'm going to say to you is small changes at a population level can be really significant in the long run. And do you think there's evidence of that? So Rose paradox, basically.
Yeah. I think so. I think the studies that we had, some of them were really large population studies. But I think that it contradicts with the qualitative. So the qualitative studies that we were aware of, which is included in this review, that lived experience researchers spoke about in their commentary, when people had the chance to elaborate and speak about their experiences, it doesn't completely marry up. So I'm not too sure.
Yeah. I mean, I think it's right, isn't it, that there was a little signal. And although that does seem to kind of flatten out, doesn't it, as in the later waves. But there's also a lot more data from the early part because people really rushed out studies. Now, obviously, that we still aren't seeing a lot of contradictory evidence, but it may be also that with longer follow-up that people are going to publish some studies that have been done at with more time that may show a bit of a clearer long-term trend. There are also these tendencies like changes in service use in 2021 where there might be something there. I guess we're saying it's not a second pandemic, is it? We can see
absolutely.
That it's not huge. So that's the thing this dispels, but it doesn't mean there's nothing there. Yeah.
Yeah, I'm just thinking of things like attendance rates in schools, isn't it? We haven't reached pre-pandemic levels. There's little indicators.
And maybe people's social interactions have changed, and maybe that makes a difference, but none of this would pick that up, really. It wasn't a tsunami, I think
Just
you can
behind you.
say that.
Thank you very much. So you focus on Europe, which I think is very interesting. Were you able to sort of identify any sort of country level differences? Because the countries have different healthcare systems and kind of, they deal with health or with sort of mental health problems differently. People go to different sort of, primary, secondary sort of care, and just anything there.
So I can answer that. So it's a limitation of our review. It's something that we would have really liked to do, and to compare the different countries. We did have a scope of it and see if there's any significant differences, but there wasn't. But we didn't do an in-depth cross comparison of countries, and it's something that we've recommended for future research.
But not obvious discrepancies, were there? There weren't, obviously, it wasn't obvious that Italy was really different or anything like that, I don't think.
Yeah, so it was just because of the difficulty of the different time points of the restrictions and the scope of the reviews of the 3 questions. But
I think I was probably thinking almost like a pre-pandemic, some of the companies put a lot more money into their healthcare system than the UK does.
Yeah.
Or, you're not actually, it's like their social care system is set up in a different way, and that, I think.
There are huge differences anyway, aren't there, across Europe in things like service use, I think, that we've seen elsewhere. Yeah.
So Rob Stewart, who I probably misquoted earlier.
I can't remember whether you misquoted me or not. I hesitate to pick an argument with Anne, but I mean, the Rose paradox relates blood pressure to hypertension. The idea is you shift population blood pressure, and there's a sort of big change in people with actually definable high blood pressure. I just think that's unproven for mental health symptoms, and for whether shifts in the population in these sort of depressive symptoms do or don't translate into people with clinical syndromes that require inpatient care or sort of significant clinical interventions. I'm not saying it doesn't. It's just there are arguments either way.
Some evidence from alcohol use, is there not, though?
That's slightly different, though, I think. Yeah. Okay. Well, yes. I mean, again, it just may not be something that you can apply. It's a bit like the kind of well-being argument that if we improve population well-being, suddenly all the mental health problems will disappear as a result, and that's the approach. Whereas I think there are quite strong arguments that that's actually doesn't work that way always.
Absolutely. And I don't know if you want to respond to any of that, or we'll take another question. I think I saw another hand flicker somewhere. Oh, yes, there.
Hi, Ellen Thompson from King's College London. I was just wondering about this whole thing around service use and about how it reduced at the beginning of the pandemic, and then you saw this slight increase. And the reason why I'm interested in this is slightly anecdotal. So I have 4 good friends who are all clinical psychologists, and they were under so much stress and pressure during 2020 and 2021. And I wonder if what we're not capturing in research studies is this whole presentation to service, but this whole referral process where people are admitted and then they sit on a wait list. So I just wondered how much the studies picked that up.
Yes, so I provided quite an overview even in the results section, but we do report the service use data based on another level where it's outcomes, consultations, presentations. And I can't remember from the top of my head, but it will be in the paper and definitely in the appendices, and it will show that there may have been longer waiting. And I know one of the service users, actually, when I met with them that worked in children and mental health services, said that there's sometimes a long waiting period as well, and it rose during the pandemic, but there will be some data on that in the actual paper.
But I think referrals did fall, didn't they, for most kinds of service. But I mean, I think there's a sense in a way that people with mental health problems were maybe at home trying not to bother anyone to some extent, or afraid of going for help because people were very afraid of infection at that time, weren't they? Or, I think it does seem that people around the world kept away from services. What they did actually it was found in another review we did, was contact voluntary sector crisis lines. So there was a 3-fold increase in one study in voluntary sector crisis phone lines activities. So they seem to have picked up quite a bit of the initial impact of the pandemic.
Sorry. Yes, go ahead. Yeah.
With you saying with reduces, I know people in my area that they weren't able to get past the gatekeeper,
Yeah.
really. So you could have a, how can I say, a less, oh, thank you, a less understanding a receptionist or whatever, that would actually put the phone down, you know, because they're not understanding that this mother was actually crying out for help. And then the child, or the young person, should I say, has gone on to even worse problems. So it would actually, you know, be treated in a different way.
And I think one thing is that services responded in quite different ways. So in some areas, they kept going as much as possible, but maybe used phone or Teams calls. But the other areas that largely shut themselves down in the onset of the pandemic. So I'm sure that's right.
That's a good point. Can I just ask you one further question? So just looking at, thank you for your question. There was a, so from the longitudinal population studies from the UK, people have measured depressive symptoms and anxiety symptoms on a kind of continuous scale. And from my reading of those, they often show that there was a spike in depression and anxiety, but that doesn't seem to be reflected in the data that you presented, which shows that clinical disorder and presentation of care, that there's not been a tsunami, but there does seem to have been an increase in, if you like, measures of misery in the general population. Is that, is my interpretation something you agree with? And how do we kind of communicating that to the public is challenging, isn't it? It's how do you think about it and present that to others?
So we did find that depression and anxiety for prevalence did increase at the onset, but there was less indication as when the pandemic progressed. There were still some increases for depression, maybe because we split over the course of the pandemic into different time periods so that we can capture the studies in the first half or later in 2020, and then only a few studies looked at 2021 across the questions, and the pattern was just less clear, but there was some still increase in prevalence of depression and anxiety, which was the majority of the study for that question.
So more consistency than
yeah.
Okay. Thank you very much. I wish we could go on asking you questions, but thanks again.
Thanks.